So in light of that, why don't we go ahead and get started? Thanks everybody for joining. For those of you who haven't met, I'm Mike Lipnick, part of the UCSF team working on the OpenOx Symmetry project. Thanks for taking the time to join today. For the next hour, we're going to be talking about education and communications around pulse oximetry, and hope that everybody can join in this discussion. I'm going to give a quick overview and then hand over to our co-chairs for this subgroup of the OpenOx collaborative community. Also share a little bit of background on the collaborative community for those who haven't joined any or many of our prior meetings. So with that, just some housekeeping. If you could, please list your organizational affiliation in your Zoom name title, just so people know who you are. Otherwise, if you are going to speak, which is completely fine, we welcome it. Please raise your hand to do so. And when you do, please introduce yourself, including where you're from. That'd be great. We are recording this meeting and we're going to post it to the OpenOxSymmetry.org community page, which is publicly accessible. So please keep that in mind. Our meeting frequency, we'll talk about a little bit more towards the end, but for the next 4 months, as we try and get out a first product of this subgroup, we're going to try and meet monthly. And then after that, expect it to go to quarterly. If you know of anybody who's not here today who you think might be interested in this, please feel free to forward them the website. The sign up is right on the homepage and they can check which subgroups they're interested in. And we welcome anybody and everybody. So this is completely open forum for participation. With that, again, the affiliations, please list those. One quick note is some of the material that we hope to generate from this committee for education purposes may end up being used for continuing medical education purposes. And for that reason, we need to make sure that it's free from bias. To do that, we're working on a strategy that will allow us to incorporate input from everybody, but also make sure that we don't end up in a situation where some of the content is perceived to have bias or has bias and then can't be used for full educational purposes. For that reason, the co-chairs of the working group and a subset of members from the working group are identified and do not have any conflicts of interest will work to make final decisions on the content approvals so we can make sure it's bias-free and has the widest potential reach. If anybody has questions about that, suggestions about better ways we can do that, we're very open to that feedback. We're still formulating that plan, so please don't hesitate to reach out. Very briefly, I'm going to go through the collaborative community overview. The objectives of this community are really to try and bring people together across different disciplines, geographies, perspectives, to try and work to make implementation of pulse oximetry safer around the world. In some cases, the community is working on very specific issues, for example, how to improve diversity of skin pigment and regulatory testing. Other subgroups are working on more engineering-focused topics. Other subgroups are working on how to do prospective clinical trials with pulse oximetry. This particular subgroup is a little bit different and is really going to be to try and share best practices. How do we communicate best practices to improve the implementation of pulse oximetry, improve education for providers and other users of pulse oximeters? So far, the collaborative community overall has had about 10 meetings now. There are about 150 members. For this particular subgroup, there are about 50 people who have signed up. I can see 25 folks are online today. And people come from a wide range of backgrounds that you can see here, including industry, regulatory, global health, and multiple other fields. We have about probably close to 20 countries represented now that span many different income levels, geographic regions. You can learn more about that on the website. We have lots of organizational or institutions who have joined as members and are participating in this, again, with quite a wide range of backgrounds here. And this list, I'll note, is an incomplete list. We have several other members. The full list will be online soon. So the collaborative community, it's clearly covering a very wide range of topics. We've tried to break it down into subgroups based on what have been the most common themes that have come out of prior meetings. So we have the clinical trials group, a group that's working on diversity of skin color, skin pigment, and clinical trials, and accounting for that in medical device testing, obviously very relevant to pulse oximetry. Another group that's doing data sharing. How do we share data, standardize data definitions, things like that. But this group is number 2. This is the education and communications group. Again, focused on communicating best practices for safe pulse oximeter use. I'm excited to introduce and welcome Leith Greenslade and Liz Igaga to co-chair this group. I'm just helping with the kickoff here, but you're going to be hearing quite a bit from Leith and Liz in a few minutes. Leith is the founder and the CEO of Just Actions. Many of you may recognize her from the Every Breath Counts Coalition, which was doing an amazing job during the COVID-19 pandemic to bring together stakeholders to improve access to oxygen. Leith's also playing a lead role in the ongoing Lancet Global Health Commission for Oxygen Security, much of which is focused on, or a large part of it is focused on pulse oximetry, improving patient safety through access to oxygen and pulse oximetry. Liz Agaga is a doctor from Uganda. She's an anesthesiologist at Makerere University, currently the director of program safety for Smile Train, and also a co-investigator for the OpenOx Oximetry project. Neither has any conflicts of interest relevant to this activity. Thank you, Leith and Liz, for joining and for moderating today. In a few minutes, I'll be handing over to you. Other members of the team that I just want to briefly introduce, because you also will be hearing from them, and they also will be on these calls with us. Fifi Neguse, many of you have seen her before as part of the leadership team for the OpenOx Oximetry project. She's a program manager at UCSF for Center for Health Equity and Surgery and Anesthesia, which is helping to convene the OpenOx and lead the OpenOx Oximetry project. Rebecca Richards-Jupp, she's the founder and creator of, founder and director rather of RRD Design. Their group is going to be helping us with generating some of the education content that includes design and kind of the overall user interface and experience of it. So she'll be listening in to try and understand what the needs are of what we're hoping to convey as an output from this project. And you'll be receiving communications potentially from her team and our team as we build stuff together so that we can iterate and get these out to a wide audience. And then Daryl Dorsey is joining the team. He's a medical student here at UCSF as part of the OpenOx Oximetry project. So the subgroup that we're in right now, again, the goal for this subgroup is to try and gather different perspectives on how we can optimize the use of pulse oximetry. We anticipate that this is going to vary across settings. It's going to vary by use case. It's going to vary by patient population. And it may vary depending on whether you're approaching that from the perspective of an engineer, a clinician, a home user, and many other potential use cases. So we're really hoping to have diverse input here. But clinicians, communication to clinicians is probably going to be the initial focus. People who are using pulse oximetry for clinical care, though we may and likely will expand some of the messaging beyond that. We want to generate through this group locally relevant materials. We don't want to create something that is really only relevant in high-income countries with very sophisticated technology and unlimited access to it. We want to make sure that we're accounting for the majority of the world's population, which is not what I just described. So that's going to be a big part of the mission of this group. The communication material that we generate from this, we want to be easy to understand. I think many of us on this call have participated in a lot of the ongoing discussion around pulse oximetry, the limitations of performance of pulse oximeters, not just the issue of skin pigment, but in other scenarios. And it's not that easy to understand. The terminology is not very accessible. A lot of the content is further only made in English. Some groups like Lifebox have done a great job making a lot of educational material in multiple languages. And so, we hope to learn from them, and probably others on this call have been doing that too. So we hope that we can gather what's there, translate into more locally relevant or easy to understand material, and then try and expand to different audiences. Over the 10 meetings I alluded to that the collaborative community's had over the last year and a half, there have been a couple themes that have come up, and this is part of the impetus for creating this subgroup to really focus in on that. This issue of, in these discussions, it has been common that we've heard, this is all great, but like, how do we communicate this to an end user? How do we communicate further? How do we communicate this to a lay audience? Because a lot of people around the world obviously are buying pulse oximeters and using themselves, or have been given one by a physician or a clinician and are asked to use it in a home care setting. That was obviously huge during COVID, but how do you use it in an optimal way? What are the limitations of it? That's not as accessible. There are a lot of places out there that have kind of touched on pieces of this, but we haven't found something, we haven't come across something that really synthesizes the evidence out there, the current evidence out there, and communicates that as effectively as we think it could be done. We're hearing that feedback a lot, so the subgroup is trying to address that. Our primary goal right now is to create a living infographic. What I mean by living is that it will be online. it will be disseminated as a web page that can be printed, but that web page will be living. If there are new data that emerge, we convene the group, we discuss, and we decide we want to update, we can update that website very quickly. And people referring to our primary product, this living website, this infographic, it will be continuously updated. We don't have to resend out a PDF. There won't be a PDF version, that's gets out of date. And so we're hoping to do this in a way where we can be nimble and make updates kind of as the data are evolving. These 4 topics are things that we've heard from folks. And one goal for today will be to see, does this encapsulate what you all think are primary messages that should be communicated via this group, or are there others? But the first one is optimal use of pulse oximeters. There's a lot that goes into that, but this is essentially kind of communicating the key messages around form, fit, and function. It's like, how do you put a pulse oximeter on? Where is it supposed to go? Where is it not supposed to go? What are potential problems? We see this a lot. We've heard a lot from the community on this, so we hope that we can really distill that down into a comprehensive but digestible part of the infographic. The next is best practices for clinical decision-making. You get a number out of the pulse oximeter. How should clinicians be using it? How should they not be using it? That has been a big part of the challenge through COVID, and why in many studies in the US, we were seeing health and healthcare disparities. A lot of that may come down to how clinical decision-making was happening with pulse oximeters. So we hope we can dig into that, and that'll involve communicating some of the known limitations, which is number 3. If you have a pulse oximeter, it's giving you a number. How much precision is there in that number? How much can you trust that number? How that's communicated right now is in something called root mean square error, which is required by regulatory bodies. That's not an accessible term. Most clinicians do not know what that is. Certainly the lay public, it's very hard. I've been dealing with this for years. I still can barely understand what root mean square error is. So we got to figure out a better way to communicate. If the device gives you a number, what are the chances that number is accurate? And if not, what's the range of what numbers it probably is? So also in known limitations is going to be these issues like the impact of skin pigment, issues of impact of critical illness, low perfusion, and a variety of, there's a pretty long list with not a lot of data, but we hope that we can synthesize what is out there and communicate that in a way that's clear. And some of that may be communicating what is unknown, the uncertainty. That's okay, but we want to communicate it clearly. And then last is an important part of the care and handling of devices and accessories. This has been a big problem. Devices may get dropped, they may be cleaned inappropriately, they may, certain parts of them may be falling apart. What is okay, what is not okay? How do we make sure the devices that are out there are operating optimally through better care and handling? And what we hope to produce is this living infographic. Again, it'll live on the website, but we hope to create it in a way that it is Creative Commons. People can take it, they can rebrand it. As long as it's not used for commercial purposes to sell a product, and its primary intent is education, then people can take components of it or the whole thing, rebrand it. For example, if a hospital wants to implement it as a poster on the wall, they can put the hospital logo on it and do it. They can change the color palette and make it fit their branding. Same thing. If a company wanted to take this and they wanted to educate their consumers and take parts of it, that's fine. As long as they're not directly selling the material as a product, then there's no issue with that. So we hope that everybody will feel like contributing to this, that the product that comes out of it is something that they all can use how they want to. And we expect people are going to want to modify it further beyond what this group does, and that's okay. But we hope that we can get them most of the way there. So here's a quick timeline of what we're looking at. I only have a couple more slides, and then we're really going to turn this over to have discussion for the rest of the hour. We're hoping over the next 2 months, really a month and a half, we can gather input from everybody. That's going to come in the form of this meeting, another meeting towards the end of April, and then in the interim, hopefully asynchronous communication. We're going to ask you to email us, send us comments, and we may create some mechanisms to accept that. Also sharing with us what you found out there, kind of what you think the best of the best that's out there, helping us identify gaps beyond what we do today. And then at the end of April, we're going to synthesize all of that, and we're going to try and create a very first rough draft of this infographic, which we'll send out in May and June for feedback. In May, we'll convene again, we'll review it together, we'll discuss, we'll revise, and then in June, we hope to pilot it. We'll discuss a little bit more and we can brainstorm. We're happy to get input, but we hope to pilot it in a couple of different settings get input from frontline healthcare providers about its utility, what it's missing, et cetera. That may come in the form of some kind of focus group sessions or just interviews with users. And then in July, we hope to revise and launch the real live version 1. So that's sort of the quick timeline. We're hoping to get a version out. And then we anticipate we're going to be iterating on this for months, if not years, as data continue to evolve on pulse oximetry, especially around this issue of impact of skin pigment. Now, beyond July and subsequent iterations, there are other potential ways that we can use the educational material that are created as part of this group. One that has come up is creating some sort of online educational module, an interactive module, less than an hour, give or take, that communicates all of the key messages that we have put in, summarized into the infographic, but with a little bit more detail, illustrations or animations rather, to demonstrate some of these concepts. And then also potentially use that module to communicate some other key messages that have come up as part of the broader OpenOx project around potential for health and healthcare disparities that result from the use or improper use of medical devices or their limitations. And so we might try to create a module. There are a number of potential partners that have expressed interest in that and have also been thinking independently along the same lines. And we hope that we can carry that conversation forward this summer and work on that into later 2024 and into 2025. So now for today, I'm going to be handing this over to Leith and Liz at this point to guide us through some discussion. These are some of the key topics that we're hoping that we can, the key questions rather, we're hoping we can answer and get your input on. So please take a look at those. And I put for reference some of the topics that have come up in prior meetings. And with that, I will thank you guys for your time and hand it over to Liz and Leith to lead us through answering some of these topics. And remember, please raise your hand and we'll try and call on you, and feel free to put stuff in the chat. Thanks a lot. Leith and Liz, over to you.
I think Liz is going to kick us off, Mike.
Yeah, thank you, Mike, and thank you everyone for being here. It's quite exciting that we're getting this started after quite a long time. My name is Elizabeth Igaga. I am an anesthesiologist, as Mike had said, and I have worked with quite a number of you and some of the people on this call, particularly with Lifebox, on quite a bit of pulse oximetry work. I think that this is really important work, and so we're looking forward to seeing what comes out of this and perhaps what else we can do with trying to get word out in terms of pulse oximetry out there. So I will have Leith introduce herself as well, and then we'll get started. Leith, over to you.
Thanks, Liz. So very, very happy to be co-chairing this group. So for those who don't know me, my role, I have two hats: the coordinator of the Every Breath Counts Coalition, which is a global coalition of more than 100 organizations now working in more than 100 countries on helping governments reduce deaths from respiratory conditions. So pulse oximetry, obviously vital tool, but also as the part of the executive committee for the Lancet Global Health Commission on Medical Oxygen Security. Commissioners met last week and agreed they want to have a very, very big focus on pulse oximetry in the Commission report, which will be launched in early 2025. So the work of the OpenOx community, particularly this deliverable here, this infographic, is of vital interest, I think, to the Commission. So very, very happy to be here and to work with you all on this key deliverable and beyond. So I think for the remainder of the time, we would love to just open the floor and have each of you weigh in, share ideas for what the infographic should be looking at. So feel free to just raise your hand. You can also put comments in the chat if it gets very crowded. Come off mute and talk a little bit about your ideas. So maybe we should, Liz, we should just start with the 4 categories that are there. So the optimal use of pulse oximeters. If we could have ideas for information that absolutely should be on an infographic under that category. And keep in mind, this is something that we envisage will be global, so eventually multiple languages, but it would be something that a health worker in a low-level primary healthcare facility, say in Nigeria, could look at and make good use of, as well as someone, in an ICU in Chicago. So we're looking for something that really can cross boundaries and levels of clinical knowledge. So let me open it up, and who's going to be the lucky first?
Riley had her hand up. And then I'll see Sandy has a comment in the chat, but I think we'll start with Riley.
Hi, yes, thank you for having me. I'm Mary. I am the Medical Affairs Program Manager for Medtronic. So I've been leading a lot of the work around education that we've been doing for pulse oximetry. One of the big things that we've seen is improper placement or use of the wrong sensors for the wrong patients. So even if it's like a pediatric sensor used incorrectly on the wrong part of the body or something like that. So that's been a big focus for us is trying to educate on the proper placement. So, you know, you can't use a transmission sensor on a reflectance area. So putting it like a sticky sensor on a forehead. So that's one of the things that we've been really focusing on because we know that, you know, we see a lot of clinicians just trying to get a number, and they'll get a number with a, you know, a sticky sensor on the forehead, but we'll see that, you know, that is not a reliable and accurate reading. So that's one of the things that we've tried to focus on and might be of interest for this group.
Great. Thanks, Mary. That's super clear. And just note the chat, everyone. There's stuff pouring into the chat. We might ask some people to come off and comment. Sandy, can you just speak to your optimal use segmentation point?
Sure. Sandy Weininger, FDA, and co-chair of the ISO Oximeter Committee. And I'll just say that we welcome this discussion and look forward to leveraging all the tools built to make the standard as robust as possible. I think part of the, and caveat, I'm an engineer, right, not a clinician. I think the challenge in oximetry use is lots of different people using it for lots of different things, all of which expecting it to do, well, they currently expect it to be perfect, and we know it's not. But there are different clinical applications which require different levels of performance. And if we can make that more clear, that would be helpful. And I just want to comment on the continuous versus spot check. It's always been an interesting construct. The standard does not go there. The standard, in fact, says whether or not your device has physiologic alarms or not, because it's attended or not attended. So we always have a difficulty defining what we mean by continuous. Over. Thanks.
Great. We're all noting these comments. Gary from Lifebox agrees. Mark, did you want to speak more to your point, Mark Ansamino? It's on the same issue.
Yeah, thanks, Leith. And thanks very much for organizing all of this. And Michael, I know you've done a lot of work in making this happen. I think it's become very evident in all the discussions we've had around pulse oximetry accuracy and the studies that we do to look at accuracy. I think there's many other factors in the use of pulse oximetry that affect its performance. And, you know, obviously signal quality is hugely important. And I think that that's a really challenging area to train people in. But I think that there is also the fact that most pulse oximeters today are designed for continuous applications, originally anesthesia and intensive care, but more and more we're using pulse oximeters for areas outside that, and particularly for single observations that we call spot checks. And I think that the devices are really not designed or manufactured to actually do that well. And I think there's lots of potential errors that can be done in using pulse oximetry as a spot check device because of this. You know, ideally, we would like to have industry design devices that limit the user from making these errors. But I think it's also really important for us to educate people about the limitations of doing when you're doing spot checks.
Limitations of spot checks. Yep. Okay.
And maybe just to give some examples. For example, it takes at least 30 seconds for the pulse oximeter signal to stabilize once you actually put the probe on. And of course, this could be, you know, enforced by the manufacturer, not giving a reading in that time, but that's not true. And the user will just look for the best number that they can see and really use that as the clinical value that they will use for making clinical decisions. But we know that it doesn't stabilize for a considerable period of time. So we need to train people to wait for at least 30 seconds before using that observation.
Right.
Leith, I just wanted to flag that Rebecca Gilbert was echoing Mary's comment about center selection and placement, and talking about a huge focus for them at Xinex is human factors and educational information on use of sensors. So I think the human factors part is something that would be nice to think about as we go forward.
Yeah, I agree. That's great. And Bob, you have a couple of comments. Do you want to come on and just talk to those? One is the nail polish issue and off-label use. Bob Kapotic?
I can if I come off mute, I suppose. Excuse me, and I was in the midst of a cough. So several comments there. Certainly, the broad application of finger-based, which is the majority of use case, especially in the home environment, needs some qualifications. So, and we need to have people to know that there's evidence. And so that's one of the reasons why I passed over that paper, which is relatively recent. It comes from the nursing profession, and they had done a nice job in Turkey in looking at the effects of henna dye as well as various nail polishes. So I think that kind of practicality component for end users, especially those that are seeing patients for the first time, such as in an emergency department, any cautions that ought to be done to avoid certain nails, etc., is important. But I also think we are dealing already with a tainted view by some medical societies that you can set thresholds for action. And I think people need to be reminded, and I think this needs to be emboldened somewhere on the education side, that this is not a diagnostic instrument. It's not a glucometer. It's nothing that you can test directly to know what the arterial value is. It's only an indirect reflection. And therefore, we need to make sure society stops saying, once you get to a threshold, you do something. You can't do that. The tool is not precise enough. Those are my points.
Thanks, Bob. Any reactions to that from others? No?
Leith, I will make a comment. Bob, I highly respect you and your comments, and I think for us as specialist practitioners, that's a very valid point. But in my practice these days, pulse oximetry is being used by frontline health workers in low resource settings around the world today, and I think it's a hugely valuable tool. And I don't believe that we can give the sort of message that you've given to those frontline health workers who often have, maybe a few months of medical training. Some of them are trained as nutritionalists and other things. In fact, we even use the guard at the gate sometimes to do measurements for us. I think that it's unrealistic to believe that we shouldn't be providing a threshold that people can make decisions on. And I understand about the uncertainty about those decisions and about the measurements. But I think still to be a useful device in those sort of settings, it would not be possible to give people an understanding of the difference between a diagnostic device and one that's used for monitoring, particularly if we're doing single observation of critically ill patients. Thank you.
Thanks, Mark. Bob, any reaction to that?
Well, absolutely. I can say from a regulatory standpoint, at least for the EU and the US, and therefore even on the ISO documents that have existed for 3+ decades, the device is listed as non-diagnostic. It is simply an indirect measure. So It's a highly flawed tool. Now, Mark, I respect you immensely. Your work in Lifebox and so many other essential ways has really saved lives. And to that end, I'm grateful. And my goodness, yeah, that's so. But recognize that perhaps a specific number, like what has been done for the ED use, when you are at 92 or less, you automatically get oxygen. I think there could be a plus or minus factor to that. And maybe that's something that the medical societies need to consider. Not a dead-on specific whole number value, but rather a range for consideration of more intense clinical assessment. That's what I have used it for in years of neonatal management, as well as my other involvement, including on animals. So if the number is suspect, look at the patient. Don't immediately treat them with something that could be harmful.
Okay. So I'm conscious of time, and we've got 3 other buckets to look at. Liz, what do you think? Should we do a little bit longer on the optimal use or move?
Clearly, it's a sticky point. I think Rebecca has her hand up one last time, so I think we should give her a chance and then perhaps move to the next bucket, and with a note to circle back if necessary.
Okay.
Sure,
Rebecca?
thanks. I really appreciated that dialogue just now. And I wanted to kind of like echo what Bob was saying of understanding that, you know, it probably is not realistic to flat out tell clinicians that under no circumstances should you be making any clinical decision-making, decisions on just a pulse oximeter reading. But I do think there is value with exploring that topic in particular, either today or in future conversations, because if that's really what our goal is here, is to educate clinicians of how to best use these tools. I think it's in this group's best interest to disclose, you know, what the risks are of using a pulse oximeter reading, you know, of just a binary threshold for oxygen treatment, for example. So I think that is an important topic to come back to. I just wanted to voice my thoughts on that. And then just to close the loop on the earlier conversation of sensor placement and selection, another thing that I think about a lot, and I would be curious of what we can come up with for this group as far as educational materials with, you know, human factors, or just how to properly place a sensor, of trying to balance something that is both universal for, you know, multiple languages, multiple countries, different education levels, while also being specific enough. Because I know a lot of the materials that I see, you know, sometimes not even have any language or words around it at all, which I think is trying to get at something that is both simple and universal, but sometimes also misses the finer details of how to really properly use a particular sensor. And so striking that balance, I think, is something that I would love to see come out of this group too.
Thanks. Mike, you've got your hand raised.
Yeah, thanks, Lee. And I may have jumped the gun a little bit, but we may be transitioning a little bit into the best practices for clinical decision-making. It was just sort of where my comment falls. So maybe I can hold it until you want to move on to that. Sorry.
That's okay. So let's just get Louise has put some really important stuff in the chat. Let's just get Louise in, and then we might transition. Louise?
Hi, I'm Louise from the MHRA. I've just put in the chat our current guidance that we have on pulse oximeters aimed at healthcare professionals. And that does say changes in the oxygen saturation value may be more important than just the number reported. I just thought that, considering the discussion, that would be of interest or note to make, but that guidance is currently being reviewed as well, so it may be changing shortly.
Okay, so we've got 3 issues on the table: a single number threshold for action, which has been questioned, a range, or now the change in oxygen saturation over time. So clearly there's some differences of opinion about that issue, which we'll have to grapple with. But Hayley, do you want to talk, last comment on bucket 1 from Hayley from Penn?
Hi, yeah, Hallie Ruppel from Penn and Children's Hospital of Philadelphia. I have spent a lot of time investigating alarms and alarm fatigue, and we have many cases where clinicians are spending a lot of time troubleshooting the monitor when there's an alarm or a number that perhaps they don't believe, while the patient is actively deteriorating. So just wanted to reemphasize that I think we need to find a balance in the messaging around both teaching people how to use the device properly and how to troubleshoot, while also thinking of this as, you know, the devices as, and the number, the estimate as one piece of a comprehensive physical assessment.
Very good. These are great comments. So shall we move? This is not the only opportunity you'll have to weigh in. This is just a first initial conversation. So let's move then to best practices. And Mike, did you want to kick us off there?
Sure, thanks, Lee. And just kind of picking up on like the discussion that Mark and Bob and several others were sharing on this issue of how to use the number for clinical decision making. I worry a little bit, just a couple of thoughts, and would love the group's feedback. So this notion of be careful with using a single number to make clinical decisions. I feel like that is, while it's true, I almost wonder if the message is lost because we hear it about everything. That's not specific to pulse oximetry. It's blood pressure, a hemoglobin lab value, like things that aren't fitting. Be careful with it, or just be cautious on some lab tests. I feel like we hear that message with a lot of different things. And so I'm not sure that just saying it for pulse ox does enough. And so my question to the group is, how do we take that a step further? And maybe back to Mark, I completely hear you and agree with what you said. But I don't know, what I'm struggling with a bit is this idea of, it's easy to communicate by giving like a cutoff. If somebody is 90% or less, admit them to the hospital, or, you know, let them through the gate, or give them steroids, or whatever that decision may be. Now, maybe setting aside the case of having somebody at the gate checking, but for like clinicians at the bedside, maybe just starting with that use case, what are your thoughts on adding for clinical guidelines, for example, or for a clinician using it, if you were to put like a plus minus and state common error amounts anytime an SpO2 is mentioned in a clinical guideline, is that still consistent with what your kind of the stakeholders that you're working with and your settings, or is that, you know, good idea, bad idea? How would you do it? How would you do it?
Are you asking me, Mike?
First over to Mark, and then Bob, love your comments too, and everybody else.
Thank you.
Yeah, thanks, Mike. You know, I think this is a very interesting question, and you know, I think that it's you know, I would consider even that challenging to do for my colleagues who work in anesthesia and intensive care in high resource settings, to try and give them a range. I don't think that necessarily goes with how we as humans think as far as clinical decision is being made. But I think that there are other strategies we can use. And I mean, just examples there, I would certainly recommend doing repeat observations. I think we know from, you know, lots of human factors and biomedical engineering research that done this, is that that's by far the best strategy to reduce the uncertainty around a measurement, is to repeat it. So whether you do that on all observations, do at least 2 measurements on all observations, or whether you only do a second measurement on an abnormal observation, or a second site on an abnormal observation, you know, might be one strategy to actually do that. I think, you know, some education around the uncertainty of this, but I think, you know, people can't remember, you know, ranges of things to actually be able to make those clinical decisions, and those need to almost be like instinctive responses to clinical situations. So it's one thing if you put it in a device, and the device gives you a display of, you know, some uncertainty around a measurement. I think that would be reasonable. But to get people to remember these things, I think to remember a range would be very challenging.
And just to add one point of clarification, yeah, I hear you. I don't know what the right answer is here. I'm just thinking of an experience of, you know, going around and polling providers just informally. I happen to be on service in the ICU, but, you know, talking to residents, medical students, bedside providers, pulse oximeter, you know, showing 92. Like, what do you think is the likely range? And most people just say like it's probably plus minus 1 of that. And so I think people underappreciate the range of true error that is known in the device, and how do we communicate that? I agree, nobody's gonna remember the actual number. I'm just wondering if it can be used as a communication tool to say, like, there is some error here. Like the number is not perfect. You don't need to remember the plus minus, and most people are just gonna focus in on the number that's given. But I'm just wondering if there's a way to communicate that there is error, not what the actual error is, especially because it's gonna vary by device, but communicate that there is error. And asterisk, I'm not sure, kind of meets that objective. And to your point of repeat measures, 100% agree. I guess I'm thinking more of the use case of somebody with a fixed error. So every time you measure, even appropriately placed, perfect conditions, you're still getting the error that's 3% off from what their functional sat in the blood is. I don't know, maybe there isn't a good solution, but that I guess is where my mind goes when I'm thinking through it.
Any reactions? Bob, did you say? Oh, sorry.
Well, I'll lower my hand and make a quick suggestion. I really enjoyed what Haley had to say, which was, don't treat the device, treat the patient. And so clinical acumen, I recognize, is not somebody that they could be trained well enough. The guard at the gate analogy that Mark gave. If somebody is short of breath, this is something that is obvious. So you need to look for reasons for it, and this may be one factor. But it could be a pulmonary embolus. There are a whole bunch of things there, but my challenge is there are already studies, especially in the baby space, where withholding oxygen because you were thinking that the values were not low enough has already, they had to abort clinical trials because of increased mortality. But yet we know too much oxygen in those preterm kids is also not a good thing. So running simply with a single value of assumed arterial blood is hazardous. So I know we've really beat the drum about this, but from different perspectives. So I probably should stop from mine, but I just worry about the increase in societies doing this, medical professional societies. We should put a caution up. I don't think they know that they are doing harm. And that's the opposite of the whole Hippocrates oaths. So just a caution from my side. Do no harm.
Yeah, no, we hear that, and this is a good flag for this area. We'll have to, I think, come back to it. But this is the purpose of this call, is to flag those areas where where there's different perspectives and we need to zero in. So I think, Liz, I think we need to keep moving because we have just 15 minutes left and 2 more buckets.
Yeah, sure. I'd like to move us to, I'm going to go to number 4 before number 3, and that is care of and handling of the pulse oximeter. Where I live, I'm not sure, at least in the hospitals that I have worked before, it's not 100% clear what to use when, with what, especially if you missed the in-service training. So I guess it would be nice to hear what your thoughts are on guidance on how to care for your pulse oximeter, how to clean your pulse oximeter, how to handle your pulse oximeter, and how to move it forward if the issue is a technical issue that is beyond the scope of a clinician.
So any views on this one? We know that, and I think often what's behind this is in many of the low resource settings where our members work, the devices break all the time and then can't be fixed. They're not stored carefully. There's just not a level of awareness about the sensitivity of these devices and how to care for them. So any insights people have on this issue, any guidance we could give that maintains the longevity of the devices, particularly in settings that are pretty rough, would be helpful. and the accessories. Do not wind cable. Thanks, Mark.
So, Leith, I've probably spent more hours of my life training people not to do this than almost anything else. But it's a one fundamental thing. The commonest failure that we actually see in pulse oximetry is damage to the cable. And although particularly the high cost devices have these amazing expensive cables, if you take it and wind it around your hand after every time you've used it, it's going to break because you twist it each time you wind it around your hand. So it's a very simple thing, but crucially important if you want to have your pulse oximeter last.
That's perfect. Exactly. Like tips like that are perfect. And Bob, you've got backup batteries, should be handy. Cleaners. Elizabeth, can you talk to that issue of the cleaning?
So what I have seen in my, oh, sorry, there's another Elizabeth. Okay. But
No,
what I was going to say is, what I've seen in my setting is some people use alcohol, some people use water, some people will use a form of Savlon or that kind of thing. And I guess it's just doing it blindly, but like Elizabeth, who will be coming on to speak after me, will likely tell us the stronger cleaners, we just really do not know what the impact of some of the stronger agents is on the plastic. So Elizabeth, please go ahead. I think from now on, I will be Liz and she'll be Elizabeth. That might be helpful.
Thanks.
Elizabeth Redall, would you like to speak to your point?
No, we can't hear you, Elizabeth. There must be something. Can you troubleshoot? Maybe while we're waiting for Elizabeth, we can take another one. Mary Riley from Medtronic. Yeah, really? You've heard that clinicians saying they can't get it done?
Yeah, we've heard it from definitely a few nurses as well as some anesthesiologists we spoke to in their training. They were like, oh, we were told that pulse oximeters could never be falsely high. You could never have a falsely high reading. And
Wow.
when we've had these clinicians speak in our education to other clinicians, we see a lot of people like nodding their heads like, oh yeah, I remember learning that. So I think that this might be something that we should address, like some of these like myths or misconceptions that they might have been taught during training.
Yep, that's brilliant. Noted. Elizabeth Redall from Nonan, can we hear you now? No. Okay. Rebecca.
I don't know if I'm going to say the same thing that Elizabeth would, but I know we also have concerns about cleaning agents. So maybe this will help since it doesn't seem that her microphone's cooperating. In general, I think that one of the things that would be most beneficial is like we as manufacturers disclose a ton of information in our instructions for use, our user's manual, about, handling storage conditions, ideal like treatment of both the accessories and the device itself. Also not to be delusional, I know that the vast majority of end users are not reading the manual and not reading it from front to back, certainly. And so cleaning is definitely a big thing as far as how to preserve and make sure the device is working in a safe way between patients, but also some of these more caustic cleaners can definitely cause plastic degradation for the monitor itself or any of the reusable sensors, which, I've certainly heard marketing and sales personnel say, oh, well, that means more sales for us. But also practically speaking, again, like hospitals, especially if you're in a more under-resourced area, are going to try to use these devices until they absolutely cannot. And usually my experience reading both our marketing material, our manuals, as well as other companies, is that the list of appropriate cleaners is usually much shorter than what is actually used in a hospital. So I think trying to provide some education on truly appropriate cleaning agents and storage conditions would be really helpful, just because I know for a fact that most nurses are not sitting there in the back of a storage closet reading manuals and instructions from the manufacturer themselves.
Right. They're often in a different language that the
Yep.
Yeah, I can't understand. So Mike's put out a tip to us, three top cleaning tips. Sounds like a good housekeeping challenge. Any ideas? Yeah, there. Let's be as practical as possible. So I assume you have cleaners. You could name cleaners that are the best cleaners for the devices. Isopropyl alcohol, Bob is saying.
Yeah, like I would probably say isopropyl alcohol is one that I see used pretty universally. I think another cleaning concern that pops to mind is certain sensors, depending on the manufacturer, provided sterile and others are not. And so if a hospital potentially has, a hospital or whatever clinical unit has multiple brands of sensors in particular that are maybe used with these multi-parameter monitors, they may be treating certain sensors in an inappropriate way of, oh, I can totally re-sterilize these, which might be appropriate for some and not for others. But yeah, isopropyl alcohol is usually a pretty universal safe one.
Well, and it's cheap, and that's the advantage there. So even if you're using something rather aggressive as a surface cleaner, for example, on ventilators or flow meters or other turnover room solutions to make sure that the next patient isn't contaminated, at least on any skin surface that a device then touches, it should be followed up with isopropyl and allowed to dry before it touches skin again.
Okay, so we've got some nice cleaning tips. Mark, Mike's asking you, what do you mean changing site? You mean moving it around to a different location?
Yeah. So most manufacturers will recommend that the site gets changed every 3 to 4 hours, which doesn't happen in most clinical settings. Newborns, obviously, is much more critically important because we do see burns commonly in that setting, but we need to decide how we communicate that and train people around that.
Okay, great.
So duration of sensor placement.
Correct.
Correct. And I can certainly confirm from a manufacturer's standpoint, that is something that we recommend as far as just worried about risk to patient skin, whether that's with skin necrosis or just bruising or swelling, et cetera, needing to check that sensor site on a periodic basis.
Okay, these are all great. I want to suggest, I know Michael probably want to wrap us up. So Liz, maybe we move to the final one, limitations. We've already had Bob give a strong shout out for warnings and things. But maybe we should talk a little bit about how we can communicate the limitations of using the device.
Yeah, I agree. And I think where I'd like to start is, I can't remember who said it, but she was talking about the fact that you have people who were told that a pulse oximeter reading could never be falsely high. It would be nice to hear what other myths people have heard versus what the true limitations are and take it from there. And perhaps also how to communicate the limitations with skin color and skin pigmentation as well, although it's not the focus here, but just to make sure that we're covering everything.
We're getting some good stuff in the chat. So Mark's got effective altitude. That's important. Bob, that your QR code on the device, is that more about bucket number 3, care and handling? So when something goes wrong, they can reach the manufacturer?
No, that could be a live link to OpenOx Symmetry. It could be a live link to that manufacturer's device's cautions about use in certain pigmentations. So it's the education link. Now, mind you, I'm sensitive to the fact that not everyone has a smart device, but it's pretty amazing how ubiquitous they now are.
Yeah. Oh yeah, that's nice. Okay, that's clear. Dr. Williams?
Hello, good afternoon.
Hello.
Sorry, my network has been bad, so I've been coming in and out of the meeting. But I've been following along with you about pulse oximeter use and how to, if it's a diagnosis tools. But I have bad network. Yeah, in Nigeria, we have a very horrible network problem. Yeah, so but I'm following. Sorry.
No, that's no problem. Great that you're joining from Nigeria. So if you wanted to share anything about, we're trying to produce this infographic that improves the use of pulse oximetry in settings like the Nigeria. If there are any issues you feel we need to really highlight in this infographic to improve the use of pulse oximetry in Nigeria, that would be really great to hear.
And just to flag that you
Okay,
type it in the
okay,
chat.
yeah, in Nigeria, we have, it's not all facilities, hospital facilities that are using pulse oximeters. Like we try to provide that in most of, because I'm the oxygen desk officer for Lagos State. So we try as much as possible to make sure our facility has a pulse oximeter working, not just pulse oximeter having it in the facility, but making sure they are making use of it. And we do some training with all the nurses, because most times it's the nurses that handle the physical exam, the vitals taking. When a patient comes in, it's the nurses that do the vitals taking, where they do the pulse oximeters, they check the SpO2, they check the weight, the height of the patient, and all that. So usually what we try to do here in Lagos State especially is that we try to train all our nurses regularly and retrain them on how to use a pulse oximeter, because most of them don't even know the correct value to say, okay, this child is hypoxemic, or this child needs oxygen, or this child needs nebulizing or anything. Most of them don't know that, because in nursing training, they mostly here in Nigeria, the trainings are usually mostly the general vitals, which is the BMI, height, weight, temperature, and all that. They don't really teach them to show them. So it's few facilities that have that knowledge. So what we try to do, especially for our state facilities, we try to train them and retrain them. But most of our facilities don't actually have pulse oximeters, because we're trying to make sure that they do have pulse oximeters. So that's the challenge we have here in Nigeria.
Brilliant. We'll come back. I'm sure we'll circle back with you when we come up with drafts of this document to make sure it works in your setting. Liz, I think we're almost at time, so I'm just going to hand back to you and then Mike.
Thank you, Liz. Thank you, everyone, for being part of this extremely important discussion. Before I hand over to Mike, and I know we're at the top of the hour, I just wanted to flag Mary's comment on misconceptions and myths. Like, if the pleth looks good, you can trust the number. If you get a number, even when used incorrectly, you can trust it. So I guess it goes back to the treat the patient and not the device. So that's also one of the myths that we would look at. So going forward, I believe we will compile everything that we have heard today, see if we can come up with some themes that look like we can put in an infographic, and then get back to some of you. And with that, I will hand it over to Mike.
Thanks so much, Elizabeth. Thanks, Lee. Thank you for chairing this. Thanks, everybody, for the discussion. A couple just wrap up things. It looks like we've gone through the topics. Again, the audience, I think just these questions here, the audience will probably be clinicians initially, but we may expand beyond that. The last bullet point, what already exists. We know a lot of people have made stuff that's out there. We don't want to ignore that or replace that. We want to just fill a gap. So if you know of good content that's out there, please send us an email. Fifi's email is in the chat. I'll flash up an email here in a second that you can send it to as well, or email any of us so that we can account for that. But I wanted to just see, Rebecca is on the call from the design team that is supporting this project. Rebecca, is there any additional information that you want to get or feedback from folks on this call as relates to us going into working on actual drafts of the product?
I think the discussion covers it, and any additional materials to review. Thank you so much for including us. This was really, really helpful, and will definitely inform the design.
Great, thanks so much for that. Again, we're really trying to compile feedback right now. Send us any materials that you know that are out there. We're going to post a summary of this meeting and anything that's shared with us on the community page, so stay tuned there. We'll be in touch with an email about an April meeting and some materials to review shortly thereafter, with the target still of getting a first version to you all in the beginning of May, give or take. So with that, we'll wrap up. Big thanks to Fifi, Rebecca, Leith, and the rest of the team. Have a great day, everybody, and we look forward to being in touch more soon. Thanks so much.
Thank you. Bye.
Thank you.
Thank you. Bye.
Thank you.